Thank you for having me. Today I'm going to talk about the somatic side effects of androgen abuse. And for the remainder of the talk, I'll just be referring to it as androgen use instead of abuse. It's a bit boring to call it abuse all the time. I'm a literature researcher on androgens, have a few papers under my belt, and there's currently one under review at the journal. And the contents of this talk are actually discussed in that paper, but in more detail, we hope to have it published in the next couple of weeks or months. So let's take a look at what side effects I'll be talking about. It's quite a list. Polycythemia, I'm gonna cover what that means. Acne, male pattern hair loss, prostate growth and cancer, high blood pressure, toxicity of the liver, dyslipidemia, so the imbalance of the blood lipids like cholesterol, toxicity to the kidneys, testosterone deficiency and infertility, gynecomastia, and to end the session with cardiomyopathy, so the detrimental changes to the cardiac structure and function. But before I do that, I want to briefly talk about a recent study that's been conducted here in the Netherlands, because I'll be referring back to the results of this study quite a lot during this talk. It's the Hallam Study, or Health Risks of Anabolic Androgenic Steroid Use by Male Amateur Athletes. It was a prospective observational cohort study of 100 male amateur athletes using androgens. And they took measurements before, during, or at the end of the cycle, and at 2 points after their cycle, which was 3 months after the cycle and a median of 8 months after the cycle. So they did blood measurements, they did echoes of the heart, and that way they got a peek at what androgens do to the human body in, well, high dosages as used by bodybuilders. The median dosage was, based on label information, 901 milligrams weekly, which is, I'd say, pretty representative of common anabolic steroid use. And the median cycle duration was 13 weeks, which is also pretty representative of common androgen use in the trenches. So that's a very quick summary of the Hallam study. And let's go to the first side effect I'm going to discuss. So erythrocytosis, or polycythemia, it's an increase in blood hematocrit or hemoglobin levels. And here at the bottom of the slide, you see 3 vials of blood. At the left, the normal composition, with at the bottom in red, you see the hematocrit, or the red blood cells, because that's what it is. It's the volume of blood occupied by red blood cells. And then the remainder is the buffy coat, consisting of the white blood cells and platelets, and the plasma, which is the water, the proteins, nutrients, and the hormones, etc., dissolved in it. And what happens with androgen use is that the percentage of hematocrit increases. So that's that file at the right, polycythemia. And the problem with this is that your blood, sort of say, gets thicker, or at least that's the simplified version of it. And the file in the center is what happens if your hematocrit decreases and you become anemic. So you get a shortage of red blood cells. And these red blood cells, they are important. They carry the oxygen to the body tissues. And so this is actually a very common side effect of androgen use. Testosterone replacement therapy is the most common side effect. And what we know about it is that it's dose dependent. So on TRT, you usually would get a lower increase in your red blood cells than if you use high dosages of androgens. But there does appear to be a ceiling effect. And the ceiling effect looks about, it occurs around 500 milligrams weekly of androgens. but the research on that isn't that definitive, but it is clear there is a ceiling effect. So at some point, your hemoglobin levels won't increase further if you up the dosage further. And then there's also clearly an age-dependent effect. So older men, they experience a larger increase than young men in their hematocrit. The increase is about 8% points in older men compared with 4% points in young men when you give them 600 milligrams of testosterone inhaled weekly for 20 weeks. So that's twice the increase. And to give you a bit of a reference range, so in men, the reference range is 42 to 52%, and in women, 37 to 47. So these increases of 8% point, they're pretty big actually. And that can push someone into the range above the reference range. And they also saw this increase in the Hallam study. So what you see here on the left, T0 were the baseline values before they started their cycles. On average, the levels were 46%. And at the end of the cycles, so at T1, it increased to a median of 49%. And each enclosed circle you see here is one of the participants' values. So you can see that quite some participants got above 52%. And in the study, they actually used an upper reference range of 50%, which meant that about 1/3 of the participants were officially polycythemic, according to their definition. And what they also saw was that at T2, which was 3 months after they stopped using androgens, the levels dropped back again to what they were, back to the baseline levels. And of course, later in time, a median of 8 months after the cycle, these levels were still normal. So in summary, you experience a pretty large increase or a decent increase in these levels when you use androgens. And when you quit using them, it drops back to baseline. But so the question is, what's the problem with this blood value changing? So like I said, it makes your blood thicker. And as a consequence, it flows a bit less well through your veins, which increases the chance of thrombosis. Or this is an extremely simplified version of things. Blood is a very difficult fluid to predict what it'll do. So you actually need some studies to back this up, but that's like the train of thought of why high levels hereof are bad for health. And so one big study, an epidemiological study done in Norway, the Norwegian Tromsø study, and I hope I pronounced that right. They found a 33% higher chance of a venous thromboembolic event for every 5% point increase in hematocrit. In men, I should say. In women, they didn't find significant increase. And this 33%, that sounds like a lot, but you also need to keep in mind that the absolute risk of a venous thromboembolic event, if you're young and otherwise healthy, is really low as well. So this 33% higher chance might translate to 0.1 or 0.2, 0.3, something in that range, absolute increase in an individual who's 35, doesn't smoke, doesn't have hypertension, stuff like that. But things are, of course, different if you are in bad shape, if you're older, which is a strong predictor for thrombosis, or if you smoke, or if you have hypertension, or atherosclerosis, things start to change that compounds the effect. And then the question that remains is like, okay, you see this correlation if you look at the population, but does this also mean that if you increase it with androgens, that it will also increase your risk? This is a more difficult question to answer. So there's no definitive answer for this. But recently a paper was published in which they looked at this retrospectively in men receiving testosterone replacement therapy. And I've highlighted this in 2 images taken from this paper. And they looked at the risk of major adverse cardiac events and venous thromboembolisms, so MACE and VTE. And basically, they took all these men from the database and they subdivided them into men who developed hematocrit levels above 52%, so polycythemia, and those who didn't. And they looked at how many of those men developed a major adverse cardiac event or venous thromboembolism. And what they found was that the men who did not develop polycythemia, here in orange, had a lower chance of developing this than the men who did develop polycythemia. And the difference in absolute terms, but these were older men, so they were more likely to get it anyhow, was close to 2% in the first year. So that's quite significant. And they did the same analysis and changed the threshold to 50%. And then they didn't find a significant difference anymore. So that also provides some support for the cutoff value of 52%. They also did the same analysis with testosterone deficient men who ended up getting testosterone or those who didn't. And then they excluded the folks who developed polycythemia from the analysis, and this is imaged on the right. And they actually saw, like, you see a small difference between those receiving testosterone in orange, those who didn't, and those who did get testosterone actually appear to have a slightly smaller chance of developing this. So this provides some evidence for it, but there are caveats to it. It's retrospective. You could argue that there is some common thing that makes these men more prone for polycythemia and thus also more prone for developing this independent of the polycythemia. So hopefully with the years, some better data will come out, but the outlook isn't that good. So what can you do about it? Well, phlebotomy or just drawing blood works pretty well. It will definitely lower the value. But strictly speaking, it's unclear if this will also affect the incidence of these major adverse cardiovascular events or thrombosis, as this has not been evaluated in this population. We do know this actually works pretty well in a disease state called polycythemia vera, in which there is, among some other things, also increase in the red blood cells being developed, and they're treated with this because these patients have a high risk of thrombosis, a very high risk. And the other thing, something I see being done by users, but also sometimes physicians prescribe it to anabolic steroid users who present with high levels, is a low dose of aspirin or cardioaspirin, which is roughly 75 to 100 milligrams of acetylsalicylic acid daily. And aspirin, it affects coagulation, it inhibits it, and so it decreases the risk of thrombosis. If your blood has a harder time of clotting, you'll have a harder time developing thrombosis. But the flip side of it is that it also increases bleeding risk, gastric ulcers in particular. And if you look at the data in other populations, it looks like there's only a net benefit to this in those at high cardiovascular disease risk. And what I mean by that is people who have like a 10% or 12, 15% risk of developing major adverse cardiovascular events, stuff like that in the next 10 years. Anyone who's younger than 40 is very unlikely to be at such high risk. And if they get older, even someone who's 50, he needs to have some comorbidities like diabetes or hypertension or dyslipidemia. So I'd say the benefit of this is very narrow and only for a few cases. So yeah, those are the two main things that are being done for this. Then to a lighter side effect, or well, one that won't give you a heart attack or thrombosis, or to say, acne. We all know what it is, so I'm not gonna discuss that much. In the Harlem study, they saw 10% of the subjects, they self-reported acne, so they said they found that they had acne, which increased to 52% at the end of the cycle, which is a hell of a lot. It will be a lot more than the polycythemia. However, when the physician assessed whether it was acne or not, 13% had it at the start, which matches quite well with the self-reported prevalence. And only, which is still a lot, 29% had it at the end of the cycle. So the discrepancy here might be caused by users self-reporting acne when they have 1 or 2 pimples, which doesn't meet the criteria for acne. So a physician will say they don't have it. This is probably the primary reason what caused this. And also a physician sees these users at set points in time. So at baseline and really at the end of the cycle and not in between. And a user who's self-reporting acne might reflect on what he experienced in the weeks before too. So that might have contributed to this difference as well. Interestingly enough, if you give men high dosages of testosterone up to 600 milligrams weekly, they don't really see a difference in sebum production. This might have been caused by a lack of statistical powers. Group sizes were about, from the top of my head, 15 to 20 participants per group. So this makes it hard to find a statistical significant difference if there's a small effect. However, they did find that the forehead sebum production was related to testosterone dose, but then again, the nose and back sebum production were not. But yeah, sebum is of course not the only thing involved in acne. It might affect follicular keratinization. So these hair follicles at the top of them, the skin cells, they shed. And something that's involved in acne is this abnormal shedding of these skin cells. They get into the hair follicle and they end up blocking the part where the sebaceous gland enters the hair follicle and adds the sebum. And apparently they also produce some more keratin, which is this protein. And it's thought that androgens somehow affect this process, which contributes to the development of acne. Users, of course, self-treat with acne, like pretty much anyone in the world does, with various supplements. Dubious efficacy, I'd say. Some work, most don't. But they also use sometimes prescription medications, or at least there's prescription medications in my country. 2 popular ones are topical retinoids, but you can imagine that a steroid user is not going to rub topical retinoids on his back if he has acne there. So something like isotretinoin, which you can take orally, perhaps better known under the brand name Roaccutane or Accutane, is much more appealing to use. And so these, they're not very commonly used, but a small percentage of users uses these drugs to treat their acne. Commonly in low dosages or lower than is seen prescribed by dermatologists for acne. These low dosages are also quite effective. I'd say there are studies backing that up with acne due to whatever cause, basically. And what I think should be kept in mind is that so some androgen users, they will go to their general practitioner and be open about their use, and they share that they have acne and want to do something about it. These people are often sent home with the message, go stop using anabolic steroids. As you can imagine, not all these users will listen to the good advice of their physicians, and they'll continue using, but they end up not being treated for their acne. And as you can imagine, someone who's very occupied with sculpting their body through bodybuilding, investing a lot of time and energy in it, it can definitely impact their quality of life having acne. And importantly, depending on the severity and the type of acne that they have, it might leave some scars on their face, for example, which are permanent. So this therapeutic inertia can definitely harm androgen users with, for example, severe acne. And I'd say a physician should treat an androgen user with acne like any other folks with acne. If they admit their androgen use and they don't want to stop, and they continue using, just treat them. Just keep in mind that it's because of the androgen, so antibiotics are unlikely to be effective. But yeah, it's something to do about. Then another cosmetic side effect is male pattern hair loss. I'd like to say the androgen-dependent condition par excellence. Historically, they saw that castrated men, so they don't produce testosterone, or they produce only a tiny bit in their adrenals. They do not develop male pattern hair loss unless you administer testosterone. So clearly, testosterone appears to be involved in this process. And they also saw that men born with a deficiency in an enzyme that converts testosterone into the more potent androgen, dihydrotestosterone, also do not appear to develop male pattern hair loss. So apparently the effect of testosterone needs to be amplified in the scalp to cause this. And the pharmaceutical industry also exploits this observation. They've developed at least one medication FDA approved and has been for quite some time now. It targets this enzyme by inhibiting it, so less dihydrotestosterone gets produced, and thus it can counter male pattern hair loss. So a key question that remains is, do high dosages of androgens accelerate male pattern hair loss, or can they cause it? This is something we don't know for sure, because it might be that the physiological concentrations of testosterone are already driving the bus, and anything added on top of it isn't contributing extra to male pattern hair loss. There's no definitive data on it, but it's definitely not far-fetched at all that it might accelerate or cause male pattern hair loss. When we look at the Hallam study, the self-reported alopecia, so the self-reported hair loss, increased from 2% at baseline to 12% at the end of the cycle. Self-reported hair loss is a bit very subjective. I'd say it's, I think, hard to accurately say if you're experiencing hair loss, male pattern hair loss or not. And one person notified me like, hey, this might be just like a temporary hair shedding, which also can occur with changes in hormone levels. So that might have been the case too. So we don't really have sound data on the prevalence or incidence of male pattern hair loss in androgen users. Regardless, androgen users, they self-medicate to counteract this side effect, because many users will experience it with over time anyhow, because most men will eventually experience male pattern hair loss. And so androgen users, one of the things they also use to counteract it is finasteride, so the medication that inhibits this enzyme I talked about. But the question is whether or not this actually works if you're blasting your body with high levels of androgens. I think it's proven first, but it's dubious at best. The reason is, if you have 10 times the regular levels of testosterone flowing through your body, does that effect still need to be amplified by 5-alpha-reductase, this enzyme, in order to cause this effect? I think these high concentrations are probably more than sufficient on their own. And then also there's the issue that a lot of androgen users stack, so they use multiple anabolic steroids in their cycles. And virtually all, with very few exceptions, one notable one would be Nanolone, actually depend on this enzyme anyhow. A lot of androgens cannot get 5-alpha reduced anymore because they already are. So it's irrelevant for those. And then there are a handful that hypothetically can get 5-alpha reduced, but they end up barely being 5-alpha reduced in the body anyhow, but you can barely measure the metabolites of it. So finasteride would only be useful in cases of a testosterone-only cycle, and most likely only when it's used in relatively low dosages. Some other medication that sometimes use minoxidil, I assume that also works for androgen-induced, if that's a thing. And there are some experimental drugs like androgen receptor antagonists, topical ones. I assume these have the potency to work pretty well against this too, but there's no good data on it. Let's move on. So prostate growth and cancer. Historically, the effects on the prostate were a large matter of concern based on a few case studies of testosterone treatment. So what they saw was that they gave men with prostate cancer testosterone an increase in a certain, I think it's not prostate specific antigen, but like the thing they used in the past, it increased in the blood. And they derived from that, like, okay, it's very bad. It makes your prostate cancer grow. And it was based on something like 3 case studies. And then I added on top of that, there were some animal experiments, one in which rats were given testosterone, and they quickly developed prostate cancer. So for decades to come, there was this image of, okay, testosterone, if you give that to men, it greatly increases the chance of developing prostate cancer. And if you have prostate cancer, it's going to make it grow really big, really fast. And on top of that, there's this bioassay, which researchers used in the past and still sometimes is used to date, called the Hirschberger assay, in which they try to predict how much side effects an androgen will have. So on the one side, you have the androgenic activity, which are basically all the non-muscle building properties of androgens and also the side effects, and the anabolic activity. And the prostate served as the model organ for the androgenic side of the equation. So this further highlighted like the importance of the prostate in the androgen research. However, if you look at clinical data, it's not that exciting really. So if you give healthy men high dosages of testosterone for 20 weeks and you give them an MRI to see what has happened to the prostate, you see that it hasn't grown at all. There's just no difference in prostate size. So that's contrary to what's happening in these animal experiments, which show a clear increase in prostate size. And also, if you give testosterone in high dosages to young men or old men, you don't really see a change in something called serum prostate specific antigen, or PSA, which might ring a bell with a few of you, as it's used as a marker of prostate cancer, and is also used in prostate screening for that. It's a protein that's secreted by the epithelial cells of the prostate, and every man with prostate secretes PSA. It's a normal protein. In prostate cancer, it's increased if you got an inflammation of the prostate, so prostatitis, it will be increased. And if you have benign growth of the prostate, it will also increase. So it's basically a rough measurement of something going on with your prostate, and that isn't affected by testosterone in high dosages. They did find a small increase in PSA levels, like pretty damn small, in the Hallam study. It's unclear what that would mean, I think there's a very good explanation for this very small increase. So if you give healthy men, so with normal testosterone levels, a lot of testosterone, nothing happens. But if you castrate a man, and so his testosterone drops really low, the prostate will shrink a bit and the PSA levels will drop a bit as well. So what happens if you have a man that's testosterone deficient and his prostate has shrunk a bit and his PSA levels went down a bit, and you re-add testosterone, the PSA levels will return back up again. So back to normal, basically, and the prostate will increase in size a bit again. And I think this was the case with the Harlem study. So some of the participants, they had recently completed a steroid cycle. So they were recently testosterone deficient, which might have decreased their PSA levels below normal a bit, or their normal. And then when they went on steroids again, it went up a bit again. So I think that would be an explanation for these results, or at least a partial explanation. And regardless, the increase is very minor. And then if you look at prostate cancer, what is seen in the literature, I've only been able to find a single case report of prostate cancer linked to androgen use or androgen abuse. So that's not a whole lot. You can imagine that if you have millions of androgen users worldwide, one case study doesn't really say much. But absence of evidence does not mean evidence of absence. So even with testosterone replacement therapy, still a bit of a question mark whether or not it can impact prostate cancer. So if it can induce its growth, if it already exists, or trigger its development if it doesn't. And the reason for this is that simply all trials with TRT to date either did not have enough subjects and simply were not long enough in duration to adequately address this question. Luckily, currently a very large study is underway called the Traverse study. It has recruited 5,200 something men in total, which are receiving testosterone replacement therapy or a placebo for a duration of 5 years. So it's a really big study, really long in time, and it hopes to address at least the effect of TRT on high-grade prostate cancer. So some good data will come out of this. But even then, if that trial is completed and it shows nothing interesting in that regard, it doesn't definitively say something about high dosage of androgens, and for that you'd need some large case control studies, as obviously there won't be a study with high dosages of androgens for years, which is randomized with a placebo. So case control studies are the next best thing for that. And then if those studies are there, then we can say with some reasonable confidence that it does not appear to affect prostate cancer, or it does, just depending on what rolls out of that. But to date, there isn't really any indication in the literature that that's the case. Another side effect of androgen use is high blood pressure. So in the Hallam study, they witnessed an increase in systolic pressure of 7 millimeters of mercury and in diastolic pressure of 3 millimeters of mercury. And if you have a threshold of 140/90 as being the definition of hypertension, then 41% of the participants ended up being hypertensive during the cycle, compared with only 16% at baseline. And I know that in the United States, with the latest guidelines, the definition of hypertension has been changed to 130/80, I think even. But these are the European definitions so far. So you can imagine by American standards, the percentage of hypertensive users would be even larger. Regardless, it's clear that this is a common side effect. And now the question is like, okay, we see this hypertension develop, we see this seemingly small increase in blood pressure, 7/3. But what does this mean? What does it mean for cardiovascular disease risk? Because that's the issue here with increased blood pressure. And so obviously we don't have really good data on that. So we have to make some assumptions and extrapolate from other sources. And one thing I've come up with, which I think gives a reasonable quantification of this effect on cardiovascular disease risk, is by looking at what blood pressure lowering medication does to cardiovascular disease risk. So if you pharmacologically reduce blood pressure, what does this do with endpoints such as major adverse cardiac events, coronary heart disease, stroke, heart failure, and all-cause mortality? And what you see is that every 10 millimeters of mercury reduction in systolic blood pressure yields pretty big decreases in all these endpoints. It's pretty substantial, like even at 13% in all-cause mortality for just a 10 millimeters of mercury reduction in systolic blood pressure. And so you can kind of say like, okay, perhaps the inverse holds true for a pharmacologically induced increase, like with androgens. And so you can roughly see that, okay, if these numbers are a bit close to the real effect, then this is very substantial. And as such, I think hypertension developed by androgen use is something that needs to be treated, or at least in long-term uses, like someone who does a cycle for 6 weeks and has an increased blood pressure for 6 weeks. Yeah, that's not really that interesting. But someone who uses for several years and walks around with hypertension caused by their androgen use, that's a whole different story. And although we don't have any data on treating high blood pressure in androgen users, and let alone what it will do with their risk of coronary heart disease or stroke, etc., I think it would be very inappropriate to not treat them simply because we don't have any studies on this. Therefore, I think it's very appropriate to just treat them like anybody else who presents with high blood pressure and treat them accordingly. With the only difference being that, well, they're athletes, so you want to prescribe something as a physician that does not affect their exercise capacity. And there are some guidelines for this, and these guidelines, they recommend ACE inhibitors and angiotensin receptor blockers for athletes, and they're also not prohibited by the World Anti-Doping Agency, which might be relevant for some of these androgen users, ironically. And alternatively, or additionally, if one of these drugs isn't sufficient to control blood pressure, calcium channel blocker is also a preferred choice for athletes. Then liver toxicity. I think it's very important here to make the distinction between anabolic steroids that are injected, like testosterone and androgen, and those that you take orally, like the few I've listed here: stanozolol, winstrol, methendione, or deranabol, oxandrolone, also known as Anavar, and oxymetabolone. These oral steroids, they have this chemical alteration. They got a methyl group alpha-oriented at the 17th carbon, and this modification limits their metabolism and thus renders them orally bioavailable. But the flip side of that is that they cause liver toxicity, which thus really seems restricted to these oral steroids, at least in healthy individuals. And so if you measure the blood in these folks, what you can see is an increase in the biochemical markers of liver damage: ALT, AST, LDH, GGT, and sometimes, depending on the severity, but this is less common, also bilirubin. Something that should be kept in mind is that exercising also increases ALT, AST, and to some degree also LDH. So if these three are increased in an athlete, that doesn't necessarily say something about liver damage being incurred per se. But if it's increased with GGT, and especially if also bilirubin is increased, those collective increases are a strong indication of liver damage, and something should be done. With androgen use, the message would be clear: just stop using androgens because things can go bad. Anyhow, regardless of that, clinical signs of liver damage are quite rare in androgen users, but they definitely do occur. And if they do, this usually presents with jaundice or this yellowish pigmentation of the skin and the whites of the eye. It's very obvious if someone has this, you can't miss it. It's caused by the increase of the bilirubin, which has this color. And this usually also comes with pruritus, which is just a fancy way of saying that it's itchy. The skin is itchy. And then there are also some case reports in the literature of pileosis hepatis, which are these blood-filled cavities in the liver that develop. These can rupture, and this can be, well, very dangerous. And of course, what's also extremely dangerous and can also be lethal is liver carcinoma or adenoma. There are a few reports in the literature about that. But I do want to emphasize these are very rare. You should not expect that if you give 100 men stanozolol or any of the other oral androgens, that a handful or even one will develop liver carcinoma or adenoma or pileosis hepatis. These are rare findings, but they do sometimes occur, and so I'm mentioning mostly for completeness. There's not that much that you can do about liver toxicity. I think the obvious message here would be just limit your use to injectable androgens and just stay away from the oral ones. And if you do want to use oral ones, keep the duration of use limited to a couple of weeks and keep the dose just as low as possible. That's just the take-home message here. And then there's this lipidemia, so an imbalance in serum lipids. I've made this neat little table here with, from left to right, LDL cholesterol, HDL cholesterol, cholesterol efflux capacity, and lipoprotein A. I've made the distinction here between these injectable androgens and these orally bioavailable androgens, again, because they exert different effects on these lipid profiles. So with injectable androgens, in general, you don't really see any change in LDL cholesterol. Sometimes there might be a small increase, but overall the effect is negligible. But the story is really different with these oral androgens. You can observe pretty large increases in LDL cholesterol. And so that's the bad type of cholesterol. It's correlated with cardiovascular disease, and it also holds a causal relationship with cardiovascular disease. So it's a very reasonable assumption that long during increases in LDL cholesterol affect cardiovascular disease risk. And then the effect on HDL cholesterol, the injectable androgens lead to a mild reduction, ballpark 10 to 25% of HDL cholesterol. And here again, these oral androgens, they shine, but in a negative way. They lead to very large reductions. 50% or more is not unheard of with oral androgens. How this translates to cardiovascular disease is a bit more difficult. HDL cholesterol is the good cholesterol, so in principle, you'd want it to be high or at least not decreased, because it correlates pretty well with cardiovascular disease. However, we know that the pharmaceutical industry, they have attempted to create drugs that increase HDL cholesterol, and they have successfully done so, I should say. Some of these drugs are capable of doubling HDL cholesterol concentration. However, these drugs ended up not affecting the things we'd be interested in, which is cardiovascular disease or mortality. So while there is an obvious correlation between the two, interventions with drugs do not appear to affect cardiovascular disease risk. And so the converse might hold true too. That's a drug that decreases HDL cholesterol might not affect cardiovascular disease too, but it might very well be the case. I mean, the outlook is grim. It doesn't increase HDL cholesterol. It's yet another marker in the blood that is being negatively affected. And so because of this lack of apparent causal relationship between HDL cholesterol and cardiovascular disease, our research has driven into the functions of HDL cholesterol, so the reverse cholesterol transport. And one of these things that they've been very interested in is cholesterol efflux capacity. So the capacity of these particles to efflux cholesterol from these macrophages, which are intimately involved in atherosclerosis. And here the thing would be high cholesterol efflux capacity would be good, and low cholesterol efflux capacity would be bad. And here again, androgens, there isn't much data on it, so I haven't been able to make a clear distinction between the injectable and the oral one, so I've just given them the same rating. But they appear to lead to a notable decrease in this efflux capacity. Just as with HDL cholesterol, the research is not fit yet to establish a causal relationship between the two, as in using medications to affect cholesterol efflux capacity will also affect cardiovascular endpoints. But yeah, clearly yet another marker in the blood with detrimental change. It's a bit different for lipoprotein A. So apparently there's a favorable effect of androgens on it, as in high lipoprotein A has been associated with cardiovascular disease and low lipoprotein A hasn't. So a decrease in it would be quite favorable. Here the thing is that it's very unclear if changing or impacting this blood value will impact cardiovascular disease risk. And it appears that about 1/5 of the world population has lipoprotein A levels that are associated with increased cardiovascular disease. So 4/5 of the world population wouldn't be affected or seemingly not affected by this anyhow, if this actually did work. So in summary, the effect on serum lipids of androgens is bad, and particularly very bad for the oral androgens. And this is again an area where users self-medicate to do something about it with various dietary supplements. I've highlighted 3 here. So red yeast rice extract is one that contains a statin. Statins are medications that are very effective at lowering LDL cholesterol. And red yeast rice extract contains lovastatin, which is also marketed and actually works. The problem with supplements, of course, is that you're not really sure what's inside of them. And especially with natural products, the contents might vary from one batch to another, from one brand to another. So you're never really sure how much of lovastatin you're ingesting. Berberine is another supplement which also lowers LDL cholesterol. And I'd assume as a consequence that it would also lower cardiovascular disease risk because of that. And niacin is a dietary supplement that's very effective at increasing HDL cholesterol. However, it has absolutely no impact on cardiovascular disease or on mortality. So it's just artificially elevates your HDL cholesterol and doesn't do anything else beyond that for your cardiovascular disease risk. So I would suggest not to use niacin. This can also trick your physician, like there are these risk algorithms that are used to see like, okay, what is your cardiovascular disease risk? And one of the inputs commonly also is affected by HDL cholesterol. So if you artificially elevate your HDL cholesterol with niacin without it impacting your cardiovascular disease risk, you're fooling these algorithms a bit, and they might underestimate your actual cardiovascular disease risk. And of course, users also self-medicate with statins. I mean, they can get androgens, and quite some androgen suppliers also have statins in stock. And these work pretty damn well for lowering LDL cholesterol. Then on to the kidneys. So there's no good quality evidence showing kidney damage, like we don't have any high quality trials with renal biopsies or anything like that. But we definitely have some findings in the literature that suggest that androgens are toxic to the kidneys to some degree or another. One thing that's seen in quite some trials is an increase in serum creatinine. And creatinine is commonly used as a marker to see how well the kidneys are filtering the blood, or the glomerular filtration rate, GFR, or the estimated GFR. But there are some pitfalls with imputation of this blood measurement. Muscular individuals have higher creatinine levels. If you've just eaten a steak a few hours before, and you can have increased creatinine levels. And there's also some evidence that suggests that androgens increase the synthesis of creatine, which is the thing that degrades into creatine. And so also dietary supplements containing creatine will increase your levels of creatinine without affecting the kidneys. So these are all false elevations of this marker. But there's an alternative marker also used to estimate the glomerular filtration rate, and it's called cystatin C, and it has been measured in one cross-sectional study with androgen users, in which it was elevated, which, yeah, it's a bit of a sign like, okay, maybe something with the kidneys is going on there. But again, it's cross-sectional in nature, which means they just took a bunch of androgen users and some non-users as a control group, and they measure this blood value at one point in time. And you can imagine that there are a lot of things which might have affected this besides the androgen use. So one cross-sectional study, it's an indication, but it's far from definitive on the matter. The follow-up trial of the Hallam Study, which is currently being conducted, is also measuring cystatin C, but this time in a prospective manner. So it's being measured before androgen use, at the end of the cycle, and again after the cycle. So hopefully that will provide some good quality data, at least on this marker of the kidney. In the Hallam study, they also measured serum creatinine, which increased a bit. And besides that, they also performed dipstick analysis of the urine to see if there's protein in the urine. Usually your urine should be virtually protein-free, not completely. There are always some trace amounts in it, but there's a low threshold above which the kidneys are apparently leaking some protein into your urine, which is bad. And they saw that this emerged or increased in 16% of the subjects. But again, here are some caveats to this measurement as well. Exercise on certain conditions can also cause this. And it's hard to say how large this increase was, because the dipstick analysis can't tell you that. And yeah, the clinical relevance, it's hard to extrapolate. But it's again a sign like, hey, perhaps something is going on with the kidneys as well because of the androgen use. And quite in fact, there are some reports in the literature of something called focal segmental glomerulosclerosis in very heavy long-term androgen users. Focal segmental glomerulosclerosis, in a nutshell, is just scar tissue developing in the kidneys. And this usually commonly is with great losses of protein in urine as well. That was also observed in these case reports. And it's quite rare disease. You shouldn't expect this in otherwise healthy individuals, although it occurs a bit more often in folks with obesity. And one thing which stood out with these case reports was that these androgen users on average were pretty damn heavy. They had BMIs above 30. So perhaps just having a very high body weight contributes to it, and it might be this cocktail. So this whole combination of long-term heavy androgen use, high protein intake, being in principle very overweight, that all together in some individuals who might be prone to it leads to the development of focal segmental glomerulosclerosis. But again, it are case reports, so it's hard to establish a causal link. But yeah, it's yet again another indication that something might be going on here. And there might simply be some underreporting of kidney damage in the literature from androgen users because urine analysis is not routinely done. And yeah, the creatinine levels are something you see commonly, but they have these pitfalls. So hopefully some future research will shed some light on this. Then, of course, testosterone deficiency. If you use androgens, it will suppress your own testosterone production. And when you stop androgens, it will not be restored the moment you quit using them. There's this delay before your own body is producing its normal amount of testosterone again. And so the question is, how long will it take before that restores? So they investigated this, the Harlem Study, to some extent, and they saw that 90% of the users that had normal gonadal function at baseline, so they had a normal sperm and testosterone production at baseline, recovered within 3 months after stopping androgen use, and 100% at the end of follow-up. So apparently, if your testosterone production is just normal, you're likely to recover within 3 months. Yeah, one thing here that should be mentioned is that the median cycle duration in the Hallam study was 13 weeks, with the longest, I think, close to a year, something like that. So perhaps this situation might be different if you've been using androgens for a couple of years. But with the regular steroid cycles, the expectation is that you'll recover within 3 months, given these results. But something that they also saw was that 37% of the subjects had abnormal gonadal function at baseline, of which 95% had a history of androgen use. And 37% is not something you'd expect. Like if I go up to the streets and I pick 100 men randomly about the age of the participants of the Harlem trial, I don't expect 37 of them to have an abnormal gonadal function. That's definitely something weird. So the question is, what caused this? Was it simply recent androgen use, so they weren't recovered yet? Or perhaps there is, with long-standing use, there might be some buildup of permanent damage to the endogenous production. So if you have androgen users who cycle on and off for a very long time and they don't recover fully in between, might there be some permanent damage? Or with these folks who use androgens for years on end? So that's another outstanding question in this area of research, whether or not androgens can cause some permanent damage to endogenous production. And this is very hard to distill because obviously endocrinologists sometimes see androgen users who haven't touched, or ex-androgen users, I should say, who haven't touched androgens in 1 or 2 or 3 years, and they have a testosterone deficiency. And then you could blame the androgens, of course, but it's very uncommon to have good baseline measurements of these men, so there might be another explanation, or they might have acquired this testosterone deficiency through some other means. So encountering someone like that is not a definitive answer to this question. We really need some good trials for that. Regardless, users, they self-medicate to speed up this process to recover testosterone in something called post-cycle therapy, or PCT. Most commonly used are selective estrogen receptor modulators, so these block the suppressive effects of estrogens at the levels of the hypothalamus and the pituitary, such as tamoxifen and clomifen. Clomifen is probably internationally the most popular. In my country, I think tamoxifen is the most popular, God knows why. And these drugs, they work pretty well in populations with testosterone deficiency. But there is a difference between men who have long-lasting testosterone deficiency due to some reason and this transient testosterone deficiency in which there is simply some lag between stopping the androgen use and the actual recovery. So it's not to be expected that those results necessarily apply to androgen users. And in the Harlem study, they had a group of people applying PCT. On average, the PCT involved a serum for about a month. And they did not observe a difference in the testosterone levels 3 months after the end of the cycle. And it also begs the question, like, if you have normal gonadal function at baseline, chances are that you'll recover within 3 months. Those chances are really good. They're roughly 90% based on the Harlem study with average cycle durations. So why would you want to speed up that even further in the first place, I'd say. And some other drugs that are being used are aromatase inhibitors. These block the conversion of testosterone into estradiol. These are exemestane, letrozole, and anastrozole, which I spelled incorrectly there. And some also use human chorionic gonadotropin, or HCG. It's a hormone that mimics LH in the sense that it binds to the same receptor, so it directly stimulates the testes to produce testosterone. There are 2 ways of using that. One is during the cycle. So you keep producing your own testosterone during the cycle, and the thought is then at least that part of the equation remains intact. And some use it after the cycle in the sense that, okay, I need to give it a kick, like a boost, get things up and running again. But the question is, if that is the problem with recovery, I think the problem usually resides a bit higher up at the level of the hypothalamus or pituitary. But regardless, for maintaining your own testosterone production, it works. And it also works for maintaining your sperm production, because that will be the next thing here, infertility. Because if you suppress your own testosterone production with androgens and their estrogenic metabolites, you also suppress your sperm production. And in the Hallam study, they also observed this. So two-thirds of the test subjects were azo or oligozoospermic at the end of their cycle. Azoospermia means that there were no sperm cells in the semen detectable, and oligozoospermic means as much as that there were some sperm cells detectable, but the concentration was below what is considered to be fertile. And this also implies that 1/3 of the subjects stayed fertile. But in all subjects, you did see a decrease in the sperm count. And so the question is, how quick does this recover? And we actually got some really neat data from hormonal male contraceptive studies. And I think we can use these because they have a lot of parallels with androgen use, as in people, they get administered testosterone often and some other drug to suppress these hormones that are involved in sperm production, so LH and FSH. So there's a very similar sort of suppression going on, virtually identical, I'd say, to what's happening with androgen use. And then after this, these researchers have looked at how quickly the sperm count recovers again. And so these are the results from a meta-analysis from a whole lot of studies. And what they saw that was the median time for sperm count recovery to baseline lasted 5.4 months. And if you look at set time points, 54% recovered within 6, 83 within 12, 95 within 16, and 100% within 24 months or 2 years. So the take home here is that recovery of sperm production is pretty damn slow. Like this is in contrast with the testosterone production we saw earlier. Like 17% of the subjects apparently still hasn't fully recovered the sperm production after a year. That's pretty damn long, and I think there are only a handful of long-term androgen users who cycle off for a year or longer, let alone 6 months, by the way. So yeah, that's really a culprit here. I think a lot of androgen users who cycle on and off, they haven't recovered the sperm production in between their cycles. And this also has a cosmetic effect because your balls, a lot of the volume comes from the developing sperm cells there. So once sperm production is halted, your balls will shrink to some degree, like 20–30% of its volume, if not more. But there's something you can do about this. So I briefly touched on ACG before, which directly stimulates the testes to produce testosterone. And it appears that these intratesticular testosterone levels, so the testosterone levels within the testes, are intimately involved with sperm production. And there are actually 2 pretty neat studies done on this that can demonstrate how ACG is able to maintain some sperm production with elevated testosterone levels. So let me go over this. On the left, what you see is men, they were given very high dosages of HCG twice a week. And first you see this drop in sperm production, in the sperm concentration. And the reason for this is that these very high dosages of ACG, they will suppress the endogenous production of testosterone and of LH and of SH. So the signal from the brain to the balls to produce sperm is suppressed. That's causing this drop. But what you see is that it won't drop to 0. It maintains some sperm production. And that's the ACG doing its job, because these high testosterone levels in testes stimulate the sperm production. And after 7 months, they also added some testosterone intake at a pretty high dosage, not bodybuild high dosages, but roughly twice that of replacement dosage. And it had no impact on the sperm concentration. So what you can conclude from that is that ACG will maintain or support some sperm production while you're using androgens. And they did another trial, roughly the same thing, so but with a nice extra. They again gave these men, that's on the right, HCG 5,000 units twice a week, very high dosage. Sperm production dropped because LH and FSH will go down to 0. I haven't illustrated that here in the slides, but it's in the original paper. They go down to 0. And yeah, they did that for 16 months, so really long time, and sperm production seems to be maintained to a reasonable degree. Like these are levels that are considered fertile anyhow. And then after these 16 months, they also added FSH to the mix. And you see that the moment they did that, sperm concentration went up. So what you can conclude from this is that if you're an androgen user and your own endogenous sperm production is suppressed, so LH and FSH have gone to 0, if you add in ACG, you have some sperm production. If you add FSH on top of it, eventually you'll likely to restore fully your own endogenous sperm production or close to it. And also not illustrated in the slides is that they've done a similar experiment with the suppression, and then they only added FSH. And likewise, like the ACG, it supported some sperm production on its own, but it requires the addition of LH or HCG for maintaining full sperm production. Something that should be mentioned is HCG is affordable, FSH is super expensive. You're looking into hundreds of euros or dollars a month if you would use FSH. So you rarely see this being used by androgen users unless they really have a desire to be fertile and get their wives pregnant, and HCG wasn't enough. But so it's good to know that it is definitely possible to remain fertile on cycle with help of HCG. Then on to gynecomastia, which is the benign enlargement of glandular tissue, the breast. I think it's good to make a clear distinction between gynecomastia and pseudocomastia, the latter in which there's just more fat tissue, which gives the appearance of breasts. And gynecomastia can be easily diagnosed if you know what you're doing. Just place your index and thumb around the area of your nipple and slowly pinch them, gently pinch them together, and if you have gynecomastia, you'll feel like this firm rubbery disc. And if you don't have gynecomastia, you just won't feel anything different than the regular tissue there. And it's also good to highlight that a lot of men have some degree of gynecomastia, very small, which can be considered normal. And I just call it gynecomastia, but it's just a normal thing. So if there's a very tiny amount of tissue there that feels firm and different from the surrounding tissue, that's pretty damn normal. So the reason I'm talking about this is because it can be caused by androgen use. And to be more precise, it's caused by an absolute or relative deficiency of androgenic or absolute or relative excess of estrogenic action on breast tissue. So in a nutshell, androgens decrease the size of gynecomastia and estrogens increase the size of gynecomastia. So what follows is that gynecomastia can develop with the use of androgens that have either direct estrogenic action, very rare, or have estrogenic metabolites. Testosterone is the obvious candidate, one of the obvious candidates here. And sometimes, because in physiological states, it can be a matter of the balance between androgenic and estrogenic action. So the ratio between the two. This is probably not the culprit with androgen users, as illustrated in this image. What you're seeing is the total estradiol concentration to testosterone concentration. And the higher the testosterone dose, the lower this ratio will be. So relative to estradiol, there will be more and more and more testosterone. And the reason for this is that this conversion of testosterone to estradiol gets saturated with these higher dosages. And thus this estrogen to testosterone ratio decreases sharply. And conversely, the testosterone to estradiol ratio will increase very sharply. So decent conclusion would be that the absolute excess of estrogen is likely the culprit in androgen users causing gynecomastia. It's a reasonably common side effect. If you believe the internet, almost everyone would get it, but the data are a bit more comforting. In the Hallam study, 7% of the subjects had gynecomastia at baseline, and 19% had it at the end of the cycle. And this was assessed by a physician. So it is common, but it's not extremely common. It's not like, oh, you're using androgens, you're gonna get gynecomastia. But anyhow, obviously users seek ways to counteract this side effect as well. And what's commonly used is tamoxifen, so this selective estrogen receptor modulator. It blocks the action of estrogens on the breast tissue, or aromatase inhibitors. So these block the conversion of androgens into estrogens as catalyzed by the aromatase enzyme. Tamoxifen is actually very effective. We know from the literature in various causes of gynecomastia that it shows high efficacy. In dosages of 10 to 20 milligrams daily, it shows efficacy in 80 to 90% of the cases and complete regression in about 60%. And I think the success rate with androgen users might be a little bit higher even, because with these literature causes, what's common is that someone has gynecomastia and they don't start treating it until after a few months or a year, something like that. And if you start treating it sooner, so the moment you notice it after a few days or weeks, it's likely that efficacy will be a bit higher too. But the thing with androgen use is that the moment you stop with the tamoxifen, and if you continue with the same androgens, you're likely to develop gynecomastia again. Another drug that's being commonly used are these aromatase inhibitors. And I'm not sure why, it's unclear why, but these show poor or very modest results in the various trials in treating gynecomastia. So tamoxifen is really the mainstay drug here to treat gynecomastia, and aromatase inhibitors should be avoided simply because they, for some reason, work very poorly against it. Then two things I'd like to highlight is that in anabolic steroids using communities, there's this belief that certain androgens increase a hormone called prolactin, and subsequently this hormone can cause something called prolactin-induced gynecomastia. There's absolutely no evidence to support this. Quite in fact, androgens per se decrease prolactin levels, and I rarely encounter significantly elevated prolactin levels in androgen users anyhow. And then there's also this thing like with some diseases like a prolactinoma tumor that's secreting prolactin, men develop hyperprolactinemia, so they have very high levels of prolactin, and indeed in some of these men gynecomastia develops, but it's secondary to the effect of prolactin on the sex hormone. So if you correct their testosterone, because the prolactin suppresses the endogenous production in some cases, and then that also resolves gynecomastia. So it's not an effect of prolactin directly, it's just secondary to suppressive effect on sex hormones, which is irrelevant in someone who uses androgens. And then there are also some users who believe that androgens have progestin action on breast tissue and thereby cause gynecomastia. So, and it's indeed the case that some androgens, they can bind to the progesterone receptor and activate it. But there's simply no evidence to support that this can cause gynecomastia. And quite in fact, there's a male contraceptive study in which they combined the administration of testosterone with a potent progestin called levonorgestrel. And over a 6-month period, no cases of gynecomastia developed. So even if you give men testosterone combination with a progestin, you won't see gynecomastia developing. So this is a really far-fetched hypothesis with no evidence from the literature to support it. Then finally, the last side effect I'll be discussing is cardiomyopathy. So these detrimental changes to the structure and function of the heart. I thought it would be nice to quickly drive us through how the heart works to have a better grasp of the results I'll be discussing. So on the left side, for the viewer, you see the right atrium. This is the part, the chamber of the heart that receives the deoxygenated blood. So the blood that has just returned from the organs, from the muscles, and it goes back to the heart. It has a relatively low oxygen level. It collects here in the right atrium. And then at some point, this valve will open into the right ventricle, and this blood will quickly flow into the right ventricle during something called the rapid filling phase. This is then followed by a slow filling phase or diastasis. And then at the end, the right atrium will squeeze to squirt the last amount of blood into the right ventricle. during the atrial systole. Then from the right ventricle, this ventricle will eventually also contract itself. And while it contracts, it builds up pressure. This pressure will close the tricuspid valve again. And then at some point, this other valve, the pulmonic valve, will open and the blood will shoot into the pulmonary artery. And it will go through your lungs and it will collect oxygen. So this blood will get oxygenated again. And then this oxygenated blood, illustrated in red, returns to the left atrium, so the left side of the heart. And here basically the same thing is going to happen. The mitral valve will open, and this pressure gradient between the left atrium, left ventricle will suck the blood into the left ventricle, first during the rapid filling phase, and then at a slow rate during the diastasis. And then at the end, the left atrium will squeeze the remainder of the blood as much as it can into the left ventricle. And then the left ventricle starts to contract. The mitral valve will close because of the pressure buildup. And with some more pressure buildup, the aortic valve will open up and the oxygenated blood will be squeezed into the aorta and will travel to the rest of your body. And the fraction of blood that is ejected by the left ventricle is called the ejection fraction, and that's an important parameter of how well your heart is pumping blood throughout your body. And I'm highlighting this because that's one of the main findings in these studies that evaluate the structure and function of the heart in androgen users. And here I'll highlight the Hallam study results. I think these are the best quality data we have on this matter, simply because it was a prospective study. So they did measurements before a cycle, at the end of the cycle, and after the cycle. And they did so with 3D echocardiography, so really state-of-the-art equipment. And I'll take you through the key findings. So what they found was that the left ventricular mass increased. And so it's this part, the left ventricle became heavier, and it was mainly because of the walls becoming thicker. So the septum here that separates the right and left ventricle became thicker. And the posterior wall, well, this is a cross section, but the other posterior at the back, the wall surrounding the left ventricle became thicker. And this is correlated with heart disease. It's a small increase, by the way, it's very small, nothing notable. Also, the increase in thickness of this interventricular septum in the left ventricle posterior wall was 1 millimeters. Usually these walls, they measure around 1 centimeter. So this isn't really a big increase anyhow, but it's quite substantial for just a single cycle that they did for 30 weeks. And you can imagine that if you cycle longer and perhaps with very high dosages, that this increase will be bigger. And perhaps if you're more prone to it, that it might also compound this effect. And that's actually something you see in some of these lower quality trials. They see these wall thicknesses really exceeding what we consider normal, and which is undoubtedly involved in heart disease. But yeah, the increases they saw in this trial were modest, small to modest. Also, something they saw was this decrease in left ventricular ejection fraction. So the percentage of blood in the left ventricle that got shoot out into the aorta to the rest of the body. This fraction decreased by 4.9% point, I should say. Usually this resides between 52 and 72%. So a 4.9% point decrease isn't much. You're not going to notice that in your daily life if you had a healthy heart baseline. But again, it's yet another signal of detrimental effect to the heart. Another thing they saw was a decrease in the EA ratio. And this ratio is quite important. It's a ratio that says something about the diastolic function of the heart. So how well it can collect blood when it's rested, so how well the heart relaxes. And so what does this EA ratio mean? So the E means is the peak velocity of the blood flowing from the left atrium to the left ventricle during the rapid filling phase. So the moment the mitral valve opens, that's the moment the rapid filling phase starts, and it's driven by this pressure gradient between the two. And if the left ventricle has a harder time relaxing, so the wall is less compliant, and that means that the max velocity, the maximum velocity of the blood will be lower. So if you measure that, that says something about the compliance of the left ventricular wall of the diastolic function. And the A in the ratio is the peak velocity of the atrial systole. So first the mitral valve opens, the blood quickly flows from the left atrium into the left ventricle. Then you got this slower filling phase, and then at the end is the atrial systole. So the atrium contracts, squeezes some blood into it, and the A is the maximum velocity at which the blood then flows into the ventricle. And so the ratio between these two measurements is a good indicator of your diastolic function. And if that decreases, that's in general bad news. And I'd say that a 0.45 decrease in this ratio is a reasonable decrease. So the ventricle has a harder time to fill up with blood. And what they also saw, and this is also another sign of diastolic dysfunction, is that the atrial volume increased. So the left atrium increased a bit in its volume and size. And this is something you also see with diastolic dysfunction. So the moment the left ventricle wall becomes less compliant, the left atrium starts to grow a bit because there's a pressure buildup in the atrium, because the left ventricle has a harder time relaxing, becomes stiffer in a way. So overall, the results on the heart can be considered detrimental. The difficulty here is translating this to disease risk. That's something very hard. Echocardiographic findings are very difficult to translate to something clinical endpoint. So that's not something we can do. But in general, just these collective changes you see are a sign of bad things happening to the heart. And of course, we know from some prominent bodybuilders, usually when you read the biopsy report, the heart has suffered quite some. These hearts are often very abnormal, very big, very thick walls. And of course, we can't measure these diastolic or systolic function anymore because they're diseased. But I bet that if they had an echo before they died, that it would show these results, but to larger extremes. And with that, I conclude my talk.